Hello and welcome to another episode of Cracking Addiction. My name's Thileepan Naren and I'm an addiction medicine advanced trainee in Melbourne as well as a general practitioner, and I'm joined by Dr. Ferghal Armstrong, a general practitioner as well as addiction medicine and lifestyle medicine specialist. Ferghal, good to have you on the show yet again.
Hi Thileepan, how are you?
Good. And on the episode today, we're going to be talking as a continuation on all the things that we've talked about withdrawal management, and we'll be talking about anti-craving medications and relapse prevention with these medications. And these are quite an important adjunct to all the things that we've discussed in the episodes earlier. So I'm going to start off by asking a few questions on the commonest anti-craving medications, Acamprosate or Acamprosate and Naltrexone. So Ferghal, can you tell us a bit about Acamprosate?
Yeah, so Acamprosate is otherwise known as calcium N-acetylhomataurine, and basically it's like alcohol in that it occupies similar receptors to alcohol within the brain, so it mimics the biological effect of alcohol. So ultimately it increases GABA neurotransmission and decreases glutamate neurotransmission, so it has the same biological effect. And I say to people, look, it's designed to reduce cravings. So imagine if you had no alcohol on board and you were thirsty and you were craving. That first pint would just be nectar to you. But imagine if you already had 6 pints on board. You wouldn't crave so much, and that's how I explain what Acamprosate does. It fills the brain with the feeling of already having had a drink, and therefore helps reduce craving. And we know that it's got a good evidence base for reducing craving and for maintaining abstinence. Some of the randomized controlled studies find that it increased abstaining by 11 days in their trials. Now, that may not sound much, but that does translate into a significant clinical effect for Acamprosate to help people reduce their drinking and actually maintain abstinence within the context of psychosocial interventions.
Excellent, and that is important. None of the things that we've talked about work in isolation, so Acamprosate is an effective medication in conjunction with a few other things. Just going back down to Acamprosate, there are a few things that we do need to be aware of as well. So Acamprosate, an effective medication, but we don't recommend it in severe liver disease, so Child-Pugh cirrhosis, and also in significant renal impairment, and by that EGFR being less than 30 or creatinine over 120 milligrams. Other than that, the other things I think to remember are dosing. And I think if you remember nothing from this episode, at least remember 60 kilograms, because that's the weight that you need to know a patient is above or below for dosing. So if the patient's above 60 kilograms, the dose of Acamprosate is 2 milligrams TDS or 3 times a day. And if they're below 60 kilograms, it's 4 tablets a day, usually 2 tablets Mane, 1 MIDI and 1 Nocte, or 2 tablets twice a day, whichever dosing regimen you want to choose. Does that sound fair to you?
Yeah, there are various dosing regimes. Just let's assume we're talking about someone over 60 kilograms. So 6 tablets a day. Now, everyone forgets the midday dosing, so there is good efficacy for 3 tablets in the morning, 3 tablets in the afternoon or evening rather than the midday dose. So you can either do 2 tablets 3 times a day or 3 tablets twice a day. And they work just as well. What are the side effects, Thileepan, of Acamprosate?
So the common side effects that people complain about can be nausea, a bit of gastrointestinal upset, feeling a bit unwell while taking the medication. And a lot of those side effects are easily explained and tolerated. So most of the patients I've put on Acamprosate, although they do grumble a bit about the side effects, the side effects by and of themselves are usually not the main reason people stop taking the medication. Is that your experience as well?
Yeah, exactly. So the side effects are not treatment limiting. It's usually perceived lack of efficacy or going back onto drinking. So that leads me on to my next question to you: is how long should you be on acamprosate for, and does that duration of treatment alter if people are starting to drink again?
I'll answer the second part of your question first, in that if someone's drinking, I usually still encourage them to continue on with acamprosate and the anti-craving medications, to be honest, just to kind of maintain that continuation with treatment. Mm-hmm. The treatment duration does depend. I guess usually we would recommend beyond 12 weeks and between 12 weeks and 12 months, but the practical answer is the treatment can be indefinite, and we certainly do have patients who have been on these medications for quite a long time period, and it is quite safe. So my advice is I would tell the patient to expect to be on this medication for the long term. We can review and check compliance and also effect, but it is a medication that will probably be a feature of their lives for some time to come. So is that your practice as well, Ferghal?
Yeah, it's a very good question. So I usually say, look, how long do you use antidepressants for? And really the answer is for as long as they work. And so, yeah, I have a very lax view on the duration of treatment, and if people get benefit from it, great, and if they don't, well, we stop it. But so I would persist with it for 6 weeks if people were continuing to drink. But if it helped people achieve abstinence, lifelong perhaps, I wouldn't stop it. There is guidance that suggests that you should, it's optimally used for 12 months, but rules are meant to be broken, and patients don't usually read guidance documents quite so well as we do.
No, if only that was the case. If everyone followed the course of Harrison's, I guess we'd probably be out of a job anyway.
Yeah, well, now, that's an interesting point. So what you're saying then is that the knowledge of health is all that is required for people to be healthy. Well, see, I would argue against that people have bad habits.
This brings me to the second anti-craving medication that we should be talking about, and that is naltrexone. Now, naltrexone is a mu receptor antagonist, and it works by decreasing the endogenous dopamine that is produced while people are drinking alcohol. So it decreases the pleasurable effects of alcohol. In your practice, Ferghal, when and how do you use naltrexone?
So, just to recap on the point that you made first of all, it's really interesting to note that naltrexone is clinical evidence of the fact that the opioid system is closely linked with the reward system for alcohol as well as for its own opioids. So, not only is heroin nice and fun, but so too is alcohol, and they ultimately intermesh in the neurobiology. But all roads lead to Rome, and all substance use leads to raised dopamine in the nucleus accumbens. And so we know that for alcohol, we can minimize the fun and pleasure and the joy that we get from alcohol by using opioid antagonists, such as naltrexone. How do I determine whether or not people get used to it? Well, there is some evidence that there's a kind of a genetic predisposition to it, so that people have talked in the past about alleles. So the ASP40 allele, which is a genetic mutation of the mu receptor, that supposedly identifies a cohort of patients that are more likely to benefit from it. But people who crave a lot, people who have a family history, I think are people that I would particularly want to try naltrexone with, bearing in mind the contraindications, which I'm sure we'll get to in a second, and compare that with acamprosate. So for acamprosate, I think of people with a high degree of anxiety, or the elderly, or people with a family history. They're the ones that I would use acamprosate for. So acamprosate for anxiety, that's how I remember that one, and naltrexone for craving.
Excellent. So we were talking a bit about naltrexone and the contraindications just then. So the contraindications would be, you mentioned heroin and opiates. So if you are on opiate medication or opioid substitution medication, then naltrexone is naturally contraindicated.
Yeah.
And also teachings do say that if your transaminases or your liver function test is 3 times the upper limit of normal, then naltrexone also should not be prescribed.
Yeah.
Is that your practice also?
Well, no. Again, we know what the rule book says, but here's the question for you. If someone was achieving abstinence as a result of being on naltrexone, would you really stop the naltrexone of the LFTs if the transaminases went above 3 times upper limit of normal? I mean, I think that, so long as they don't have decompensated liver disease, I think overall the benefits of being on naltrexone, if it is contributing towards abstinence, outweigh the risks of being on naltrexone. But I am aware that this is a controversial point and is going against the rule book. But, what's your view on this?
I think it depends on the patient and it depends on the liver function tests. If you can monitor the patient and the liver function remains stable and the patient is having a good clinical outcome, we know that continued drinking is hazardous for your health, hazardous for your liver function, and will lead to further complications, including potentially cirrhosis and decompensated liver disease.
Yeah.
But if someone can be maintained in abstinence and we can monitor their liver function and there's no significant deterioration, I'm with you. From a harm minimization point of view or a harm reduction point of view, in a situation like that, I would probably be inclined to continue on with the naltrexone.
Yeah. So what would you say are the common side effects for naltrexone?
Usually people complain somewhat similarly to Acamprosate of diarrhea, abdominal bloating, nausea, and some GI upset. Those are the common side effects that I hear about a bit. Again, usually not treatment limiting, to be honest with you.
Yeah.
It's usually something else that causes people to end up turning off naltrexone. Has that been your experience?
Yeah, some people for me report fatigue as a side effect, but yeah, so those are the usual side effects. But then we've got to bear in mind that yes, naltrexone is listed that naltrexone does cause liver derangement, which is ironic because it causes liver derangement, but it's treating a condition that causes even worse liver derangement. So, I mean, in terms of choice of anti-craving medication, I mean, basically, if someone's got really bad liver derangement, you tend towards Acamprosate. But if someone's got really bad renal impairment, well, then you tend towards naltrexone. So, and also in terms of therapeutic goals, because, they say that, as we've already just said, Acamprosate supports abstinence and naltrexone prevents relapse, or at least it prevents a lapse from becoming a relapse. But then that opens the door into what we call the Sinclair method. Could you talk a bit about that?
So the Sinclair method, or pharmacological extinction, is when one takes naltrexone half an hour to an hour before drinking. And what the theory of this method is, and it is quite effective, is that it decouples the sensation of deep drinking and pleasure.
Yeah.
So basically, by following the Sinclair method, we're getting rid of that reinforcing mechanism with alcohol where we drink for pleasure. We drink, but we get no pleasure. And then once we realize that, we end up stopping drinking. And it is quite an effective technique. I've certainly seen it work quite well. But you do need a patient who is quite disciplined and will continue to follow the paradigm for the Sinclair method. Very similar to a patient for Disulfiram or antabuse, which we will segue over to. So Disulfiram is another one of the aversive therapies that we use for alcohol use disorder. And Ferghal, I don't really have all that much experience prescribing Disulfiram. Have you used it much at all?
Well, I have used it, but I don't have a vast amount of prescribing experience either, and I think that speaks to the fact that it is very much third line or even fourth line in relapse prevention medication. But first of all, if we understand what it does, so basically it inhibits aldehyde dehydrogenase. Now, why is that important? So we know that alcohol is metabolized by alcohol dehydrogenase into acetaldehyde. And we know that acetaldehyde is metabolized into ethanoic acid vinegar by aldehyde dehydrogenase. Now, acetaldehyde is toxic and causes incredibly severe hangovers, amongst other things. So normally what happens is that the relationship between alcohol dehydrogenase activity and aldehyde dehydrogenase activity is very closely aligned. So really, when we drink alcohol, we don't actually experience any buildup of acetaldehyde. It goes straight to vinegar. But if you inhibit that enzyme deliberately, what you do is for every molecule of alcohol you ingest, you're creating a molecule of acetaldehyde, which makes you feel really sick, and that's what disulfiram does. So it gives you, as you've said, this aversive experience. So every time you drink alcohol, you feel like puking and you feel flushed and you're terrible and you've got this pounding headache. So you think, oh, I'm not going to go through that again, therefore I'm going to abstain from alcohol. But as you've also said, these therapies only work if you take them. So, using the Sinclair method only works if you take it. Using naltrexone and acamprosate regularly for relapse prevention only works if you take it. Using disulfiram only works if you take it. And further to that, the evidence of efficacy is better if you have daily pickup or directly observed administration by pharmacists, which doesn't really happen with disulfiram in Australia. It does in the UK. So that's how it works. There is evidence that it does actually increase the likelihood of abstinence within the first 12 weeks of therapy, but beyond 12 weeks, it's not proven to be any better than acamprosate or naltrexone. What do you think about the side effects and the contraindications, etc., for disulfiram?
I think there's a reason why disulfiram is third and fourth line, and it's mainly because the side effects can be quite significant, especially if you're dealing with a compromised patient with already compromised liver disease or renal disease. Because we're talking about aversive therapy, because people get flushed, they can feel nauseated, they could start vomiting, sometimes get quite significant gastrointestinal side effects. Some patients are at significant risk of dehydration and electrolyte abnormality, and if you're already compromised, that can be quite fatal. So again, you have to choose the right patient for the right treatment, and as I mentioned earlier, my experience with disulfiram is limited, and it's not something that I've prescribed or am all that inclined to prescribe, if truth be told.
So I think of the contraindications to disulfiram with the mnemonic PAINE, P-A-I-N-E, so psychiatric contraindications you don't get with people with unstable mental states. A for allergies, like most things, and I for ischemic heart disease. So we know that actually increases, causes dyslipidemia. So if you've had ischemic heart disease or a heart attack, you shouldn't be on it. And then N for nursing, so it's problematic for pregnancy and breastfeeding.
Oh, and Ferghal, we were talking about contraindications and special populations there as well. Harkening back to our earlier discussion about acamprosate and naltrexone, acamprosate is B2 in pregnancy and naltrexone is B3.
Yeah.
In a pregnant woman who is drinking at hazardous levels, what would your process and opinion be in commencing one of these anti-craving agents?
So we know that alcohol is teratogenic. And unfortunately, there's no safe amount of alcohol that we can say to moms, look, you can drink this much and you're not going to risk baby. Any amount of alcohol in pregnancy is potentially unsafe. We also know that in terms of the risks of fetal alcohol syndrome, the biggest risk period is the first 3 to 4 weeks of pregnancy. So most, 50% of moms don't realize they're pregnant, and so they're drinking and they're perhaps binge drinking during that high-risk part of pregnancy. But fundamentally, alcohol in pregnancy, I think, is more dangerous than acamprosate and naltrexone in pregnancy. So again, it goes down to risks and balances. But overall, I believe that for most patients, the benefits of these anti-craving medications outweigh the risks of these anti-craving medications in view of the reduction in alcohol-associated problems, in particular the fetal alcohol syndrome.
Absolutely, and I couldn't agree with you more. This is all about harm reduction.
Yeah.
These drugs may not be category A, but the effects of not using these drugs could be devastating. So I'm with you, Ferghal. I would not hesitate to prescribe this to patients who are at risk of relapse of alcohol use disorder in pregnancy.
Yeah.
Now, moving on to some other medications, which are probably outside the scope of most general practitioners in terms of relapse prevention medications for alcohol use disorder. Baclofen is a medication that we sometimes use for as an anti-craving agent. What are your thoughts about Baclofen, Ferghal?
Well, first of all, it's quite dangerous. It's a GABA B receptor agonist, so it can be problematic. But the history of Baclofen in the context of alcohol use disorder started out in France when there was a French cardiothoracic surgeon who finally managed to overcome his own personal demons with alcohol. And he managed to achieve what he described as la belle indifférence, which means the beautiful indifference. So with high doses of Baclofen, he was able to walk past a drink and not really want one. So it does achieve that for some people, but I think the effect is dose dependent. And, for spasticity, we might be using maybe 5 to 10 milligrams TDS. For alcohol use disorder, some people advocate even going up to 100 3 times a day. I think you have to be very careful with it. I think it very much is not first or second line, so it's third or fourth line. And also bear in mind, one of the side effects of Baclofen is stomach ulcers. So, you're giving someone who's got a precarious gut lining because of exposure to alcohol another drug that is potentially going to cause a stomach ulcer. So, again, it boils down to risk benefit. However, if someone has had a good go at Acamprosate, a good go at Naltrexone, or if those drugs are contraindicated, I would start, or I'd talk to them about the possibility of Baclofen. And I'd start low and go slow, and I'd push the dose up to maybe 20, 25 TDS before I'd say, look, it's probably not going to work. I'm not as brave and as adventurous as the European physicians who push the dose right up to 100 milligrams 3 times a day.
Absolutely. And I think also with cessation of Baclofen, our viewers, if you are going to go down that path, just remember, do not stop it suddenly.
Yes.
The Baclofen must be weaned down just because there are risks of seizures and withdrawal symptoms if Baclofen is ceased rapidly. But I think the take-home message is it is an option. There are significant side effects and it can be dangerous. So I would probably consult a local addiction medicine service or specialist before starting this in primary care practice. Would that be fair, Ferghal?
Yeah, look, I don't believe that anybody, even addiction medicine specialists, should be operating as a solo practitioner. You need a team around you. There are no lone rangers in recovery. I don't believe there are any lone rangers in the management of addiction in general. So, have a chat with your team members, have a chat with your colleagues, have a chat with your network. It should these kind of treatment decisions should never be made alone. And I certainly don't make these treatment decisions on my own. I always chat to colleagues.
Absolutely. And I think the last medication we'll touch on briefly is Topiramate, which is a anti-seizure, anti-epileptic medication, which has some use as an anti-craving medication. I'm going to be honest, I've never used Topiramate as an anti-craving medication. I've used it for many other reasons, but not as an anti-craving medication. Have you had any practical experience with Topiramate as an anti-craving agent, Ferghal?
No, I haven't used it as an anti-craving agent. I've used it for epilepsy and I've used it for migraine and various other types of primary headache syndromes, but not anti-craving. But theoretically, it can be used. There is an emerging evidence base for it in terms of anti-craving, both for alcohol and also for food. So, it is co-formulated with Zyban. As a drug called Contrave. So, there is an emerging basis to understand its effect on the reward system, both for food and alcohol. But it's very much not first, second, third, or even fourth line.
Absolutely. So this has been yet another episode where we've gone through a fair bit of information. We'd like to thank you for joining us on this journey of this episode and the series thus far. Thanks very much, Ferghal, for your company again on this episode, and to our viewers, bye for now.